Welcome to the research seminar that's sponsored by the College of Public Health and Human Sciences. And I'm Marie Harvey, and I'm the Associate Dean for Research. And I'm pleased that you're joining this seminar today. And I'm also really pleased to introduce Sunil Khanna, who is the Robert and Sarah Rothschild Endowed Chair and Professor of Global Health in our college. And because of his overlapping interests in, I would say, focused on vaccine hesitancy, he has agreed and is pleased to introduce today's speaker and to moderate this session. Sunil will also provide more instructions about the actual format of this webinar. So without further delay, let's move forward, and please join me in welcoming Dr. Sunil Khanna. Sunil, you're on.
Thank you, Marie, and good afternoon, everybody, and welcome to the Friday Research Seminar. And we are so glad that you are able to join us for CPHHS research presentation via Zoom. Just a little bit of housekeeping notes. What we have done is we have muted all of your microphones. So if you want to ask a question, please use the chat feature in Zoom. We will be moderating the chat section and repeating questions for our guest today. Now, it is my distinct honor, and I'm very pleased to introduce Dr. Courtney Campbell, our speaker for today. Dr. Campbell is the Hundier Professor in Religion and Culture and is the director of the program in Medical Humanities in the School of History, Philosophy, and Religion at Oregon State University. Prior to joining OSU in 1990, Dr. Campbell served as a research associate at the Hastings Center, a think tank for medical ethics. He received his Ph.D. and master's in religious studies from the University of Virginia. As a scholar in medical ethics and religious ethics, Dr. Campbell is interested in some of the very critical and difficult ethical issues in medicine and health. He has authored numerous articles on the Oregon Death with Dignity Act and the Oregon Health Plan. He has also authored papers for the National Bioethics Advisory Commission on the ethical questions of human cloning and research on human tissues. His book, Mormonism, Medicine, and Bioethics, was published this year. He has also authored the book with the title Bearing Witness: Religious Meanings in Bioethics. The title of Dr. Campbell's talk today is Who Shall Live When We All Cannot Live? Ethical Issues in COVID-19 Vaccine Prioritization. Please join me in welcoming Dr. Courtney Campbell.
Thank you very much, Sunil. I have long admiration for Sunil's work and our collaborations. And I also want to thank Marie for this invitation. I've had a long I've been at Oregon State for 30 years, so I've had my own encounters with public health in terms of, sitting on doctoral committees, and now more recently with the medical humanities program that I oversee. Many undergraduates, I'd say about 35 undergraduates, are in some form of the public health or other kinds of health sciences program. So it's an honor for me to be able to address you and hopefully have some conversation today. I'm just going to pull up my slides here. Just as a preface before sort of launch in. Again, this particular presentation draws a lot on my sort of work with the State of Oregon Ethics Task Force on pandemic response, as well as my consultations with Samaritan Health Services and with Lumina Hospice, and of my own interactions with students that I've taught courses about recent courses on pandemics and ethics literature and in history. So I want to just, even though I'm going to raise some critical points about how the COVID-19 vaccination prioritization has occurred, I don't want to underestimate. I mean, it comes with a very important caveat. I don't want to underestimate the magnitude and the scope of this public health undertaking. To vaccinate, at least, initially, all adults or all persons age 16 and up with emergency use authorization vaccines in so far a 4-month period. 198 million vaccines have been disseminated. I received my second shot today, about 2 hours ago, and so hopefully I'll make it through this seminar without any side effects. But again, to think about the magnitude and scope of what the US and ultimately other nations in a global pandemic are trying to do is very, very striking. And so again, some of my ethical perspectives need to be set within that recognition that this is really something that is rather unprecedented, and it's to be understood that certain kind will have some blips, some glitches, and so forth. But those are issues of implementation are different than some of the ethical questions that I want to address. So let me just start, if I could, by providing a couple of illustrations that sort of not so much with the rollout per se of the vaccine phases, whether recommended by national bodies or what's happened in the state of Oregon, but just some illustrations about where we are roughly 4 months into the prioritization or the distribution of the vaccine. So this is just how the vaccine has been allocated in Oregon as of this past Monday. And you can see some differences based on race and ethnicity. A particular concern certainly is the differential allocation with respect to Hispanics in the state of Oregon, which account for 13% of the total population, 34% of the cases in the state of Oregon, 11% of the deaths, but so far have received only 7% of the vaccines. There's a question here because Oregon's allocation process was based on a principle of health equity. That was sort of the primary ethical principle and public health principle as has been articulated by the Oregon Health Authority. That essentially, well, here I'm quoting from the Oregon Health Authority on this. Oregon will have established a health system by 2030 that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined characteristics. So again, there's a very profound commitment to this principle of health equity that says we're going to make decisions and provide the best kind of healthcare, irrespective of other kinds of social categories and so forth. And yet, as the vaccine has been distributed thus far in the state of Oregon, we've seen some inequities or disparities. Second sort of consideration to keep in mind is Oregon rather uniquely set up or the Oregon Health Authority set up a vaccine advisory commission comprised of 28 persons from all sorts of ethnic groups and health advocacy groups across the state. I mean, it's enormously diverse composition on that commission. I mean, that commission is now, it had four meetings to make recommendations about health equity allocation, and is now sort of no longer operative, although you can certainly see their recommendations on the Oregon Health Authority website. The goal of this Vaccine Advisory Commission, or that's charge given to it by the Oregon Health Authority, was to create a vaccine sequencing plan that would, again, be focused on the principle of health equity to ensure that the needs of systematically affected populations, and obviously there's a disproportionate impact in terms of hospitalizations and infections and mortality, as indicated by this particular slide. So again, to focus on the needs of the systematically affected populations, including communities of color, tribal communities, and people with intellectual and developmental disabilities. So again, there's a very profound commitment, I think, in the allocation as it was the allocation process as was articulated by the Oregon Health Authority within the state of Oregon, and yet, for all the good ideals, we still have some disparities. What's going on here? Why doesn't the vaccine distribution reflect health equity? Well, clearly part of the story, which obviously will get into matters that you all are much more skilled at than I am, is various kinds of social determinants of health, obstacles to access, be they language, be they transportation, communication or lack of communication infrastructure, concerns about employment, with many people losing their jobs over the past year, and given our employer-based healthcare system, you lose your job, you're likely to use your healthcare benefits, and thus lose access to primary care physicians, which are the primary resource that people trust to give them reliable information about COVID-19 in general or about vaccines. 80% of the American population trusts their primary care physicians to be the most reliable source. So there's a lot of, again, if we're trying to explain why there's some of the disparities, particularly with Hispanic population, what, you ultimately are pushed back into looking at sort of public health concerns of the social determinants of health. Now, this will come as, this is national data. This is from the CDC as of March 12th, so a month or so ago. Not able, for some reason, it hasn't been updated, or at least I haven't been able to figure out how to get it updated in the last month or so. But this is as of a month ago. And again, you can the bars, the blue bars for each of the groups, American Indian, Alaska Native, Asian, Black, and Hispanic, refer to the numbers of cases relative to the white non-Hispanic population in the United States. Now, just as a as a caveat here, the CDC does not have data for not all states provide information with respect to cases, hospitalizations, mortality based on race and ethnicity, or vaccinations for that matter. So the database isn't quite as robust as one would like to see that. But given that the blue bars represent the relative number of cases amongst these different population groups, relative to if the white and non-Hispanic population was at 1.0, what would be the proportion of cases, hospitalizations, which is the orange bar, or mortality relative to the white population at white non-Hispanic at 1.0. So again, you can see with Alaska, American Indian Alaska Natives, with Black population and Hispanic, less so with the Asian population. There's, again, some very significant disparities with respect to numbers of cases or incidents of infections, those that are serious enough to require hospitalizations, and then those that ultimately result in mortality. This particular slide indicates, so you've got this background that certain demographic groups, certain racial or ethnic groups are disproportionately affected. This is no news to you by any means. Disproportionately affected with respect to, again, the incidence of infections, serious infections requiring hospitalization and mortality. And yet, in an odd kind of way, some of these groups, again, the data here from this slide, from the Kaiser Family Foundation, indicates that with respect to the communities that are disproportionately impacted relative to COVID-19 are, at least with respect to Blacks and Hispanics, are receiving a lesser proportion of the vaccines. 20% of the Black population overall nationally has received at least one dose, 19% of the Hispanic population. And yet these are the communities that are disproportionately affected. The vaccination rate for white non-Hispanics is 1.7 times higher than the rate for Hispanics, and 1.6 times higher than the rate for Blacks. What's going on here in terms of the rollout and the disparities that we're seeing here? It seems that the communities that are most impacted, or at least relative to their proportion in the population, what we're seeing is sort of a legacy, the continuation of a legacy, a perpetuation of how marginalized communities experience less adequate health care in terms of their access to vaccines, given their disproportionate impact of COVID-19 on these particular communities. And then let's just, this will be looking at this. I mean, there's not only an issue of vaccine equity within the state of Oregon or within the United States nationally, but this comes from the Duke Global Health Initiative Innovation Center. There's also an issue about global equity. If we're in a pandemic that affects every nation and and people, as indicated by the WHO director recently. The pandemic will not be over anywhere until it is over everywhere. If you're in a global pandemic, you have to think about responsibilities beyond those to the. You have to think about equity outside one's own particular nation and state and so forth. This particular slide indicates the number of doses of vaccines that have been purchased or contracted. These have not been delivered, but you can see from this that there is what are called the high income nations have roughly made contracts for close to 65 to 70% of the overall vaccines. Now this again comes from earlier this month. It's not April 16th, but it is as of April 1st, this particular slide. So there's an issue as indicated by the WHO. There's a great concern about vaccine nationalism. The sort of global approach, the COVAX community, the collaborative community, again, has been able to sort of purchase. These have not been delivered again, at least some of them, most of them haven't been, just over 1 billion vaccines. The United States, as perhaps know, has yet to contribute any of its supply of vaccines to COVAX. There have been President Biden did make a $4 billion donation for purposes of purchasing vaccines a month ago. But this, so if we look at, again, this might be a little bit hard to see. I don't know why this didn't quite come out as well as it should have. But again, from the Duke Global Health Innovation Center, you can see that who the high income countries are listed. I haven't provided the whole slide here. It's just enormously lengthy, but you can see that, for example, Canada has enough vaccinations contracted out. Again, not necessarily online yet, but at least purchases to vaccinate their population close to 9 times. UK 7 times, the US at about 4 times. And then the first country that isn't considered a high income country is Morocco, interesting enough, at 2.5 times. So there's some very interesting considerations to think about, not only health equity within the context of Oregon or within the context of the United States, but also with respect to, again, if you're in a global pandemic, you have to take care of the entire globe and not just focus only on national priorities. When the National Academies of Science, Engineering, and Medicine put together a committee to develop priorities for vaccine allocation within the nation, but also they made a specific recommendation with respect to global health equity. And they argued that the US should deploy a proportion, for example, 10%, what's kind of be known in sort of the literature as a vaccine tithing. 10% of the US vaccine supply should be deployed for global allocation as a means to help contain the global pandemic and as an effort to build global solidarity in addressing this pandemic and the next. Okay, I mean, again, be somewhat short-sighted to say we've got it all figured out this time. They went on to say, amid the catastrophic COVID-19 pandemic, the US should consider it a moral duty and ethical responsibility to embrace its humanitarian legacy by leading on the international stage in support of lower resource nations. Now, again, that hasn't happened yet at the global level. President Biden, again, a month or so said, basically laid out a sequentialist approach. We're going to take care of the U.S. population first, and then we will take care of the rest of the world. Taking care of the rest of the world will mean that many, the estimate is that the lesser resource countries will not have, will have roughly about 20% of their population vaccinated by the end of this year. The entire global population, maybe 2023, 2024. So there's reasons for obviously a stockpile of in the US. I mean, this was raised by President Biden and some of his task force advisors, concerns that there would be manufacturing disruptions. We don't know quite how the variants are going to work out. We still have to consider vaccinations of children and so forth. So we want some additional in case something, as, for example, happened this week with respect to the Johnson & Johnson vaccination, need to be put on pause because of some risks that have been determined in 6 cases of serious blood clots with 1 more mortality or fatality from that. So there's a reason, there's some understandable reason for having, more than just 1 per or 2 if it's a double dose regimen. But do you really need 4 times the amount necessary to vaccinate your country's population, or in Canada's case, close to 9, UK a little bit more than 7. So that's, again, just a kind of some snapshots locally, Oregon, nationally, and then globally about how the issues of health equity are playing out, or in a way that suggests, health equity is an important principle, but it's been difficult to operationalize this. Now, let me just sort of go back to last summer with those first few slides saying this is kind of where we are at now, with some elements of inequities, disparities, lack of adequate vaccinations for individuals and communities that seem to be disproportionately impacted. So going back to last summer, as there was certainly an anticipation that given research that was being done on on vaccines, but no clear understanding of when those vaccines might be approved for emergency use and what have you. Various groups, and the one I'm going to draw on here is the National Academies of Science, Engineering, and Medicine, started to develop ethical frameworks for what was considered to be an equitable allocation of the COVID vaccine, anticipating that there would be shortages initially, depending on how quickly the manufacturing could be ramped up. Again, this is in the absence of knowing whose vaccine research might actually be productive. Some have panned out clearly, as with Pfizer and Moderna and Johnson & Johnson, and others didn't, like Merck. But anticipating that there would be some need to develop an allocation framework, the National Academies of Medicine and the Advisory Commission, Advisory Committee for Immunization Practice at the CDC developed some global or national guidelines for allocation and how this might be rolled out. They were trying to avoid some lessons from past allocation fiascos, some of which have occurred, frankly, in the Pacific Northwest, not with respect to vaccinations, but with other forms of innovative medical technology. So they're trying to avoid providing allocation based on judgments of social worth or social contribution, because those become arbitrary, and then they also can skew the allocation of a scarce resource toward in a way that isn't equitable at all, may be efficient, but isn't equitable at all, and brings in arbitrary judgments of social contribution and social worth. They're trying as well to avoid free market principles. That is, that some processes by which people might be able to use their financial resources to buy their way up or purchase their way up the queue, so to speak, to engage in what's called vaccine jumping, because they have financial resources, communication resources, transportation resources that others don't. So again, part of the goal of these allocation procedures was to focus on ways to limit the impact of privilege and financial availability. Public trust in allocation in general requires fairness and transparency. And if it looks like some individuals are able to use their networks, their financial resources to engage in vaccine jumping, you're going to diminish both the trust and transparency. So again, that was something that they were trying to avoid, and also to try and avoid the use of age as except as a tiebreaker kind of situation. Obviously, age has relationships to impacts on or the impact of COVID on based on a person's age and their risk of a serious infection, risk of acquiring infection, and a risk of a serious infection such that they need hospitalization because of the diminished immunity. But the goal of these frameworks was really to try to engage in, to the extent possible, making these judgments about who might get prioritized based on sort of standard medical and public health judgments. That is, who needs the resource, the scarce resource, the most, and who has a good probability of benefiting from the resource. So this particular slide isn't this is drawn from the National Academy's report on this. It's not I don't know, I'd set it up a little bit differently, but I go with what they have. And I want to highlight initially that the allocation framework that was developed for an equitable allocation drew on three particular ethical principles. First was, and you can see those sort of at the very bottom down here, with the scarce resource, to try to provide a maximum benefit from the use of the resource. That would include protecting and promoting the public health, or the public's health, and its socioeconomic well-being in the short term and in the long term. The second consideration, which would play into some of the issues we already mentioned, is equal concern, to treat all persons as moral equals, having equal dignity, worth, and value. So again, goes back to health equity, goes back to principles of justice, a requirement of treating all persons as equals, eliminate sort of social judgments, social categories in the allocation process. And then third, and this again would speak to the issue of health disparities, inequities, to try to mitigate health inequities, which they specified as including the obligation to explicitly address the higher burden of COVID-19 experienced by populations affected most heavily. Now, clearly that's going to be those in aging population or elderly populations, healthcare workers, but also the racial and ethnic communities that we looked at right at the start. Then there were, in addition to the ethical principles, what they designated as procedural principles. I tend to think of these as ethical principles myself, but they are talking more about here's the process that needs to be set in place. The principle of fairness, which for them meant engagement with the public, particularly those most affected by the pandemic. The principle of transparency, communicating openly with the public, clearly, and providing clear, accurate, and straightforward information about the framework or the allocation framework, and then evidence-based. And we need to make sure that the allocation framework is based on sound science. And again, sometimes we may need to take a pause depending on if we have some scientific evidence that shows up about the impact of the vaccine on certain individuals. That led the committee to the National Academies Committee to then develop a criteria of allocation based, and you can see that in the central box, sort of prioritizing individuals based on the risk of acquiring infection, severe morbidity and mortality, negative societal impacts, and transmitting infection to others. So this led the committee to, and again, this was largely adopted by the Advisory Commission for Immunization Practice of the CDC, sort of 4 phases, although phase 1 was broken out into phase 1A and phase 1B. Phase 1, you'd provide priority to healthcare workers and first responders. If they aren't protected or they don't have the vaccine, then you're going to have a hard time vaccinating the rest of the population. Phase 2 then, or I'm sorry, phase 1B was to address individuals with all individuals that had significant comorbid conditions that again would place them at higher risk if they had the infection of a very serious infection and higher mortality, as well as older adults in congregate care settings, residential facilities, and the like. That was deemed to consider to bring into, at least in phase 1, roughly 15% of the general population. Phase 2, and we'll come back to this in just a minute, phase 2 in this national approach was to focus on persons that worked in school settings, K through 12 settings, critical workers in high-risk settings, then persons that may be at risk because of moderate comorbidities, but not significant or high comorbidities, persons in homeless shelters, persons incarcerated in prisons, and all older adults that weren't part of phase 1 and phase 1A and phase 1B. Phase 3 then was to include young adults, children, workers in important social industries with moderate exposure risk. And then finally, phase 4, all others residing in the US interested in receiving a vaccine. So again, those 4 phases were a way to try and provide an orderly, fair, transparent, and allocation process that, again, maximized the use of a scarce resource, treated persons as equals, and tried to mitigate the health inequities. So that's how that allocation process was put together, or its background, its philosophical and ethical background. Now, let's turn just briefly, and I know you won't be able to really see this. It's the Oregon approach, which, one thing to keep in mind here is you have national approaches, but when you don't have a sort of a national healthcare system, and you leave things up to the states are going to do things differently. That's a strength in some ways, and also create some deficiencies in other ways. So Oregon's process, for the most part, followed the general guidelines of the national recommendations by the National Academies and the Advisory Commission of the CDC. But there were some important kinds of considerations where Oregon was different. And the first, again, I don't know how well you can see this, was really phase 1B. I mean, phase 1A was really sort of similar to what was recommended at the national level. But phase 1B, Oregon, along with Idaho, really the only two states that said, we're going to give greater priority to K through 12 teachers and staff and childcare workers and the like. They're going to receive higher priority than individuals that, again, might be at higher risk because of age or comorbidities and the like. That was clearly a very controversial determination. I felt, personally that, again, everyone wanted to see the schools open, no question about that. But the reason the vaccines were developed was to treat people or protect people that are highest risk. And so if you were redirecting the vaccines in Oregon towards really to a social goal, an important social goal to provide some earlier opening for the schools, in some sense, you were using the scarce medical resources for a different purpose than they were originally designed for, to protect people from infection, hospitalization, and death. You were using medical resources for a social purpose. And that would raise, again, some issues about health equity that I mentioned previously. The other kind of the other kind of controversy about the Oregon model, you can see this is kind of, as of Monday, it's going to be open to everyone. This document has changed several iterations, but initially, Oregon was going to make sure that the vaccines were open to everyone by July 1st. Now that's been moved up to April 19th. The question that came up basically in early March was, why not follow the lead of other states and open it up to everyone and not have these sort of group categories? One concern that we wouldn't have enough vaccines, so you'd have some kind of stratification that would be necessary anyway. There were still 3 million adults needed to be vaccinated in Oregon, and Oregon was only receiving roughly 250,000 vaccines a week from Pfizer, Moderna, and J&J. So you still, if you just open it up to all comers, as other states have done, you'd still need to, you need to either have some kind of prioritization process, or what you do is reinscribe privilege into the allocation system. People that have better access to communication, to information, to transportation, to job flexibility would sort of be able to engage in vaccine jumping. So those were at least two major concerns. There are many more with how Oregon ended up doing their own vaccine rollout, but at least two major concerns that I thought had some very significant ethical questions about them. Now, let me I've just got a couple minutes and I just want to close. This is something, again, Dr. Khanna can speak a lot more better than I can, but I just want to indicate, again, it's interesting to understand that when the national academies put their proposal together, they're very cognizant that there was a background of vaccine hesitancy, and they developed certain kind of priorities and health promotion campaigns to make sure there was a vaccine uptake. This particular slide comes again from the Kaiser Family Foundation, and it was also actually in the New York Times today. What's the vaccine uptake and what's the vaccine hesitancy? You can see as the headline there is 1/3 a report having received at least one COVID-19 vaccine. This was as of March 12th again. The share wanting to wait and see because maybe they'll be able to draft off herd immunity, or they'll wait and see if it's needed for travel, or they'll wait and see if they need to have a vaccine to come to OSU in the fall. Like OSU doesn't seem to be going in that direction, but other universities have. That's shrunk by 40% to 17% since the vaccines were rolled out. But you can see there's also kind of a level of resistance, either only if required, only if mandated, or definitely not. That is still roughly 20 to 25%. And if that continues to persist, it's going to be very hard to get to herd immunity if that sort of 20 to 25% is not only there won't have the vaccine uptake. This is we can drill down a little bit further on this. I think because of time, I'm not going to just spend any time on this, just to indicate that the groups with the highest level of vaccine hesitancy are first members or persons that are affiliated with the Republican Party. That clearly has sort of political ramifications and political rhetoric, but in the context of the political system, Republicans are 54% either in the wait and see, or only if mandated, or definitely not, and the highest level of definitely not, which is 29%. The other point just to mention here is perhaps not surprising, there's certainly an overlap demographically, is the level of resistance or vaccine hesitancy amongst white evangelicals. Again, the second highest level of vaccine hesitancy at 49%, either wait and see, only if mandated, or definitely not. And as far as definitely not, 29% of white evangelicals say definitely not. The others we may want to come back to in questions and so forth. I just want to finish up here. When the groups that are vaccine hesitant are, what's their concern? Again, you can kind of sort of see concerns about serious side effects. Again, the J&J is a serious side effect. How it's a serious side effect to have blood clots. Now, the probability of that seems to be relatively low, 1 in 1 million, but it's a serious side effect. So that's perhaps certainly an important aspect of getting the vaccine. Might be getting worse than COVID. That's perhaps a informational consideration. Again, concerns about vaccine mandates. The third level might have to miss work, might get COVID-19 from the vaccine. Again, some misinformation, issues of trust there. So, part of the discussion about vaccine hesitancy has really been about sort of the distrust narrative of distrust of science or distrust of government, just distrust of authority. That's an important kind of narrative, but that's not unique to COVID-19. I mean, that's part of the vaccination story. That's part of the political landscape we live in. So we need to consider some of the reasons that are maybe unique reasons that people are vaccine hesitant with regard to the COVID-19 vaccine, and especially the emergency use authorization, which hasn't, because it's an emergency use, we don't have long-term longitudinal data to sort of lay out to people that might allay some of the concerns. So just to conclude, again, just a couple of other, just to go back to this issue where, again, the primary ethics principle for vaccine uptake or vaccine distribution is really the principle of health equity. We seem to be falling short. The graph on the left is, again, from the Kaiser Family Foundation. The graph on the right is from the CDC. You can see that, again, there's some differential impacts, and there are ways that we need to sort of start to walk the talk with trying to live by the ethics of health equity and the principle of maximizing the best use of a scarce resource to ensure that we mitigate health inequities. Okay, so I'm gonna, sorry, ran a few minutes longer there, but I'll end there and see what questions that you have.
Thank you, Courtney. Thank you very much. And as always, every time I listen to you, I'm just struck by the depth and the breadth of your knowledge about the issues that you talk. And it's always inspiring to listen to you. I have so many questions to kind of ask you, but I'm just going to wait, see if people from the audience have any questions for you. So I'm going to just wait for maybe another 5 or 10 seconds before I start my questions. So if you have any questions, folks who are listening to the presentation, please put your questions in the chat box and I'll be happy to read those questions out to Courtney. Okay, so what I wanted to do was to pick up my first question was the place where you were ending up in terms of looking at vaccine hesitancy, especially among the white evangelical community, and it's about 45 to 49%. And one of the arguments that that is being talked about, that they are hesitant because they believe the vaccine includes human fetal cells. How, as an ethicist, how does one respond to that kind of a reason for hesitation?
Yeah, so there's two kinds of points there. I mean, those that are concerned, it's really with the Johnson & Johnson vaccine, the mRNA vaccines, the Moderna and Pfizer, they have a different manufacturing process. But the Johnson & Johnson vaccine has been developed from cell lines that, goes many decades back, that involve fetal tissue. Now, for Roman Catholics, which are different than white evangelicals, for Roman Catholics, this has been viewed by the National Conference of Catholic Bishops and certain archbishops, the Diocese of New Orleans, for example, as making this a morally compromised vaccine. And the recommendation was not to get the vaccine, but to see if it was possible to get the the Pfizer or the Moderna vaccine. But they did not say if Johnson & Johnson is your, what's offered to you, to refuse that. so there's an issue. I mean, the degree of there's a concern in Roman Catholic teaching about moral complicity in a previously what's deemed to be a previously unethical act, that is retrieving tissue from aborted fetuses. There's such a tenuous connection between again, aborted tissue that is really from 3 decades old, that cell lines have been cloned from and so forth, that again, you haven't had, I mean, you've had some concerns again from pastors and from dioceses and even the national conference saying this might be morally compromised, but they haven't said don't get the vaccine. So I think that's important. The white evangelicals is a different kind of category, and perhaps some are concerned about the fetal tissue, but for the most part, it's COVID there really isn't a pandemic. I mean, it's, again, white evangelicals are the largest basis of support in the Republican Party. So it's playing off that kind of narrative. So COVID might not be as serious, or it's not a pandemic, or if I get COVID, again, I'll rely on the healing powers of the divine or of God. And that's, we certainly have in the state of Oregon, we've got numerous sort of faith healing communities that unfortunately have applied some of those teachings to children that haven't been treated for childhood diseases and the like, and have subsequently died. And Oregon has changed its laws to restrict religious liberty on those bases. But now we're seeing that kind of same mentality work itself out with respect to white evangelicals with respect to COVID-19. And what's striking to me is, again, I respect certainly traditions that say ultimately that the source of healing comes from a divine authority or divine power, God, or some other kind of source of energy in the universe and so forth. But does that really mean that you don't accept medicine as a way, and the medical profession as a way through which these healing powers are operationalized to the rest of the population? I mean, it's not only about the vaccines, it's a concern about medicine. And that, to me, I don't think is justifiable on the general views of white evangelical Protestantism. It's a deeply concerning and kind of deeply puzzling perspective. But again, it's this idea that COVID isn't really serious, and if I happen to get infected, I'll find some healing power elsewhere.
Thank you. We have a question in the QA from Caroline Aldrin. She says that on the last slide, there seemed to be discrepancies in the percentages, but it went very fast. Can you please elaborate? So we may have to go back to the last slide to see.
Yeah, let me. So there is a little bit of discrepancy. You're right to note that from one of the slides that I popped up right at the start. It said that Asians and whites had received the vaccine at roughly 32%, and Blacks and Latinos or Hispanics at about 17-18%. That's partly a function of time. This particular slide, I think, is again from April 5th. The other slide is a little bit more recent, as of this week. So people are drawing. I mean, frankly, this comes from the Color of Coronavirus, the APM Research Lab, which has done a lot of really interesting information. They're drawing, as you can see there, they don't have information from all states. whereas the slide I popped up earlier did have sort of all states included. So this one is a little bit limited. I just wanted to pop it in there just to, again, see that there's some differences between, in terms of demographic groups. The slide on the right comes from the CDC, at least as of, again, from March. What they're doing there is, the blue bars are the percentage of population that are fully vaccinated of the white population. So, for example, 65% of the people that are fully vaccinated in the United States thus far, again, whites at 68%, Asians at about 8%, Hispanics and Latinos about 15%, Blacks and non-Hispanics at 12%. So this slide, the slide on the left, is looking at people that have received one dose. The slide on the right is people that are fully vaccinated, okay? And so that's part of the reason for why there's a little bit of discrepancy between those two slides. Is, again, one's looking at one dose, the other is looking at a total dose. The other thing about this slide from the CDC is the gray bar, which doesn't show up too well, is what's the percentage of the U.S. population in the demographic category. So, again, if we were doing it proportionately, you would have, again, more amongst the Asian population, more amongst the Hispanic and Latino, and more Black and non-Hispanic. So that's, again, it's part of it. So part of the discrepancy in the two slides is, again, one's focusing on one dose, and the CDC slide is, or the CDC graph is on fully vaccinated.
Courtney, it's always a struggle. We have very little time left, and we have so many more questions for you. I'm not sure if our panelists are still around. Yes, so the question from one panelist is the question I wanted to ask you. Could you briefly tell us about your most recently published book, Mormonism, Medicine, and Bioethics? Just give us a little snapshot of it, please.
So Mormonism is the fourth largest religion in the United States. There have not been any books written on medical ethics. So I decided that's what I'd be interested in doing. And what I do is outline some basic principles that I think are applicable to any ethical system in medical ethics. And then I look at how those play out in various kinds of specific topical issues, including vaccinations, infertility treatments, genetics, organ transplantation, access to healthcare, end-of-life issues, care for newborns, seriously ill newborns. So that's that's the sort of the short version of it. I guess the one thing that the thing that to me makes it really distinctive is I draw very heavily on personal impressions, personal stories of people that have been living these experiences, living out their faith commitments, and run into some medical ethics issues that they're not quite sure what to do with. And so the stories really carry the book more than sort of my academic kind of analysis. But thanks for asking. I'm happy to send anyone a gratis copy if you're really that interested in it.
Thank you, Courtney, and thank you very much. And I also want to take this opportunity to thank Dr. Harvey for organizing this seminar series, for Jacob and Gretchen for helping us with this. And once again, thank you to Dr. Campbell for accepting our invitation and talking to us. And then finally, to all the participants who attended the seminar. Thank you very much.